So trauma in the pediatric patient occurs a lot, especially with head injuries. A pediatric's head is really large for their body size, so it makes them kind of clumsy. And they tend to fall and hit their heads a lot, bang into things with their heads. So head trauma becomes a common occurrence. So how do we assess somebody that's had a head trauma? We're going to talk about that. Children that are less than 3 years of age will love to put things in their mouth. They're in the oral stage. And when they're putting things in their mouth, it could go to the back of their throat and then they can inhale it into their lungs. So that happens a lot. Matter of fact, we'll start with the foreign body oscillation on those. All right, so how can we tell that something has been aspirated into the child or the baby's trachea? We'll notice a sudden onset of cough or wheezing that wasn't there prior. So they're not sick, they haven't been ill with a fever, and they're crawling around and all of a sudden they're coughing. That's a sign that they've put something in their mouth and it's in the back of their throat. So once they inhale it into the lungs, it'll narrow the airway, but may not necessarily occlude the airway. So if it narrows the airway, you're going to hear a lot of wheezing because air is getting past the object, but it's narrowing the airway, so you'll hear wheezing because of it. So taking the infant to the ER and an x-ray is done, and you'll see what's on the x-ray. A bronchoscopy may be necessary to remove the foreign object. If something gets inhaled deep enough where it goes into one of the lobes, it'll cause atelectasis of that lobe. So if it plugs up the airway, then any air getting beyond that is impossible. And then the air that's in the alveoli will be absorbed and then they will collapse. So you'll have atelectasis in that area. All right, so here's the scenario. You come across an infant that's coughing and wheezing. You come across an infant that develops sudden coughing and wheezing. What should you do? Should you do a finger sweep and try to remove the object?
No.
Why not?
Because you'll push it even further.
Yeah, it's possible when you're going with your finger that you're pushing it deeper into the airway. So if you're not removing it, then what?
You should try and visualize what it is.
Heimlich? All right, so with coughing and wheezing, does that mean that there's air exchange occurring?
Yes, there is.
Yeah. So if air is getting into the lungs and out of the lungs, they're going to be coughing, they're going to be wheezing. But if air exchange is occurring, you don't do the Heimlich, you don't do a finger sweep, you don't have to start with back blows, unless the airway becomes obstructed. So now let me ask you, there's no air movement, and the infant is turning blue, what do you do? Yeah, so now you lay them down with back blows. And back blows, can you do Heimlich on a 6-month-old?
No.
Would you do a Heimlich on a 3-year-old?
Yeah, I thought.
No. Is it 8?
Oh, 8 years?
Years of age,
okay.
you can do Heimlich? Yeah, so you have to avoid abdominal organ compression when they're younger.
You have to kind of like hit them. You have to hit them, right?
Yes.
Yeah, you turn them over and then you
Turn
just.
them over. You put the head lower than the body.
Yeah.
Do the back blows.
I remember that. Yeah. Back
Very good.
blows. That sounds silly.
And you can do chest thrusts up to 3 years of age also. So not only can you do back blows to try to loosen whatever is obstructing the airway, but you can also do chest thrusts. All right, this shows a baby that has a jack. Does anybody even know what jacks are?
Yes.
Yeah. You throw the ball and you catch all the jacks.
Yes.
I had a childhood.
You had a childhood?
Before video games, this is the game.
Yeah, I remember jacks.
Yeah, it's so
Yeah,
bad.
first you have to pick up one, next time you have to pick up two.
Two, and then, yeah. And then try picking all of them up.
Yes, okay. So if those are left on the floor, then of course the crawling infant comes by and, oh, what's this? Let me put it in my mouth, and it can end up in the trachea. I would imagine that it could easily end up in going down the esophagus into the stomach too.
Oh, God.
So if it ends up in the trachea and air is getting past it, then there's wheezing and coughing. You need to take the child to the ER. But if there's complete obstruction, that's when you start trying to establish an airway. Okay. So head trauma is a frequent occurrence. There's one head trauma or one brain injury occurring every 15 seconds in the U.S. It is the primary cause of traumatic death in the U.S. So it's not hurting the arm or the leg or the abdomen, it's the brain. In children less than 1 year of age, it's most commonly caused by falls because of the large and heavy head relative to their body, and because they are not yet fully coordinated. And they're also the most vulnerable to falling and getting a head injury from the fall. The second one listed is automobile accidents. So you would think that, oh, we have a state law where an infant has to be in a car seat and they have to be strapped in. But sometimes a car seat could be in the back seat of the car and it's not strapped in. So yeah, the car seat's back there, but you forget to strap it in. So, or the infant was crying, so mom puts the infant in her arms to hold the infant to try to console the infant, and that's when the car crash happens. So there's still brain injury even with car seats. And then shaken baby syndrome is a baby that's crying and the caregiver shakes the baby to try to stop them from crying. And when you shake a baby, they don't have strong neck muscles, so it causes the head to fling back and forth. And when the head is flinging, the brain inside the head is flinging. And it can damage the brain permanently from that occurrence. So when you go to Kids Corner in next semester, you'll visit the long-term care facility. And there's kids in there that are there because of shaken baby syndrome. It damages their brain, and the rest of their lives they don't function normally because of the damage. So something that's very preventable. "89 to 95% of infants aged 4 months to 5 years who had falls of 8 inches to 10 feet had no significant long-term problems." So that's a good thing, considering how often head trauma happens. It's good to know that they don't have any long-term problems, or most of them don't have long-term problems. Infants have a malleable skull. Do you know what that means by malleable?
It's soft to touch.
Right, so the bones haven't hardened yet, and because it's malleable, that could be a good thing because if there's swelling, then the swelling can, the brain can have a place to go where the fontanelles are, like the bones haven't fused together yet.
Oh, where the sutures are supposed to be?
Yeah,
the spaces.
the sutures, yeah. Yeah, so there's space, and sometimes the swelling won't cause high pressures inside the brain because of the fontanelles, and there's a place for the extra fluid to go. So this will lessen the severity of the trauma and prevent high pressures in the cranial vault. So I guess the underlying message is when high pressures build up inside the brain, that's what causes brain damage. So the brain can't tolerate high pressures. Do you recall what the normal intracranial pressure is inside of our skull?
Like 30.
Yeah, less than 30, about 20 centimeters of water, 20 millimeters mercury, I'm sorry, is normal pressure inside the skull. So if the pressure goes to 25, 30, 35, it's that excess pressure on the brain that damages the brain tissue. Oh, that's all it says about that? All right, sometimes, now this is, I guess it can occur with the pediatrics, but in adults, you'll see this a lot where they're in a car accident, they come in, they have damage to the brain, and they bore a hole in the skull and put in a shunt so that when pressure builds up, it evacuates some of the fluid in the brain to prevent any more higher pressures. So you'll see an intracranial pressure monitor, and there's also a way for the excess pressure to be vented to prevent pressure from rising and causing the brain damage. All right, next is child abuse. Suspect child abuse if the child draws away or cringes when the parent approaches. So if the child is playful and communicating with you, and then the parent walks in the room and all of a sudden they stop their play, or if they're talking, they stop talking, that's a sign of fear of the parent, and possible child abuse has occurred in the past, and that's why the child's behavior changes when the parent is in the room. Also notice if the infant has multiple bruises of varying ages. So having a fresh bruise, having an older bruise, it's possible that the child is being battered, not just once, but repeatedly. Suddenly becomes nonverbal or behavior changes when the parent approaches. That kind of goes along with the first bullet. All right, assessing head trauma, the Glasgow Coma Scale is used. Have you heard of this from previous lectures?
Mm-hmm.
Where if there's brain injury or neurologic injury, how can we tell? Well, somebody who becomes comatose isn't going to respond to pain, they're not going to open their eyes, they're not going to be verbal. All right, so that's Glasgow Coma Scale. It's considered more accurate in older children and adults than in infants, but it gives you some numbers here. You need to look at the scale. All right, so eye-opening, verbal response, and motor response would be movement. So if the eyes open spontaneously, or if you say open your eyes and the person can open their eyes, you would give them a score of 4. If they're talking, or if you ask them questions and they can respond, or if a baby can coo or babble, that's considered a normal verbal response. A normal motor response is following commands, lift your arm or squeeze my hand. That's a normal response. And then it can diminish from there. And the lowest score that you can get is a 1, because if you don't open your eyes at all, you still get a 1. If you're not responding to verbal commands, you still get a 1. And if you're not moving and you're just laying there, you get a 1. So the lowest score you can get is a 3. All right, so let's back up. So it's less than 4, there's an 80% chance of dying or having permanent neurologic damage. So there's been a head trauma, and now you're assessing the infant or the child with head trauma. And they don't open their eyes, there's no movement, there's no verbal response. That's a score of 3. And what are their chances of having permanent damage, permanent brain damage? About 80%, so it's pretty high.
Are these numbers just for peds, or can you use for adults?
Adults, yeah. Greater than 6, there's very low risk of permanent neurologic sequelae. So if they're, let's see, for eye opening, if they open their eyes to pain, or verbal response, they're moaning or not making really good responses. If they're withdrawing from pain, then they get, what is that, 4, 6, 8. So they get a score of 8 if they're doing something, and that'll indicate that they're going to recover. But less than 6, no. Greater than 6, they have a good chance of normal neurologic recovery. All right, if somebody's had a head trauma and they need to be intubated because they're not responsive, is it okay to hyperextend the head and intubate them? And what do you think?
No,
So what would hyperextending do that?
that can further damage the brain.
Yeah, so if there's a cervical spine injury and you move the spine, that can cause worsening damage. So if these patients need to be intubated, it's better to use the, am I going to remember the
glide?
name?
Oh,
The C-spine?
So use
Oh,
C-spine to
C-spine.
stabilize the head?
yeah, somebody stabilized it.
Yeah,
Yeah.
It's like this.
yeah, all right, very good. So with head trauma, if you have increased intracranial pressure, how can you get the pressures to be lower? You use hyperventilation, get CO2s down low and create alkalosis, and then that's going to lower the intracranial pressure if you just prevent as much perfusion from going to the head. We've talked about this before, where hyperventilation isn't practiced as much anymore, because if you hyperventilate a patient and you reduce perfusion to the head, it worsens their neurologic outcome. So here it's saying you can do it for a couple hours, that's it. Now you've got to figure out another way to reduce the pressures in the brain. Don't just hyperventilate as a reason, or as a way to reduce the intracranial pressure. You want to maintain good cerebral perfusion pressure. Do I need you to know any numbers for this? No, just what's written there. So cerebral perfusion pressure, the way to calculate that is you need to know the patient's blood pressure, and then you calculate the mean arterial pressure. So that MAP, if you want to write it in your notes, that stands for mean arterial pressure. Then you need an intracranial pressure reading. So ICP, intracranial pressure. And then you subtract the two to come up with your cerebral perfusion pressure. So having good blood flow to the brain is going to actually help. It says to keep the cerebral perfusion pressure greater than 50 millimeters mercury. So let's say it's an adult, you have a mean arterial pressure of 90, and the intracranial pressure is 20. What is the cerebral perfusion pressure?
70?
Very good, 70. So 70 millimeters mercury is a normal cerebral perfusion pressure. And as long as it's greater than 50, you're getting enough blood flow to the brain. All right, with injury, it's considered mild injury to the brain if the patient goes unconscious, but it lasts less than 5 minutes. That's got to be a scary 5 minutes, doesn't it?
Yeah.
Like if they fall and they're not responding, Glasgow Coma Scale is 3. I mean, I'm already in panic mode, life has ended. So it's possible for unconsciousness to occur and then to gain consciousness within 5 minutes. Or they could become paralyzed just from the shock to the brain, and then within a few minutes start moving around again. Severe injury is considered where the patient is unconscious greater than 5 minutes, or they have seizures, they're disoriented, or they have a persistent headache. So severe injury is usually, of course, an ER admit. The swelling in the brain gets worse after about 24 hours. So it's possible that they're fine a few minutes after the insult or the injury, and they're responding to commands. Can they go home? And the answer is no, because it's possible with an injury that it gets worse in 24 hours, or 24 to 48 hours. So they need to be admitted for observation. A lot of times, wherever the impact was, the bruising of the brain can occur on the opposite side. Can you figure out why?
Because like the
Brain
whip,
hit that side.
the whip backwards could just hit the other side, I guess.
Yeah, so the brain comes forward and then it recoils back and hits the back of the head. And so if it's a forward injury, the brain snaps back and hits the back of the head harder than
Then yeah.
the frontward injury.
Gotta hurt.
So this shows a picture of the impact, and then the back of the brain gets some bruising. All right, it's called a concussion if there's loss of awareness for a few minutes. It's called a contusion where there's a bruise to the brain. A skull fracture is linear when the bone has been fractured, but it doesn't move. So in order for the bone to move, it would have to be completely moved away from the rest of the bone and be impressed or depressed inward.
It's like essentially just a crack, like a crack in the skull, versus it like moving out of place.
Right.
Is that what you're saying?
Yeah, so I guess it would have to be completely cracked in order for the bone to let go and move
Yeah,
into
just
the
like fall out.
skull.
Yeah.
A basilar skull fracture can damage the brainstem. You'll notice leakage of fluid into the eyes and ears. The position that a person's body assumes after head injury can be diagnostic of the level of brain function, whether it's cerebellar, which would be your higher functions of your brain, or cortical, which would be your brainstem. So with decerebrate posturing, it doesn't explain decerebrate posturing. Oh, there's a picture. All right, the first one is talking about is letter B, decerebrate posturing. Do you see how the arms are against the body and the hands are turned outward?
Oh, that's like
So it's that outward turning that's common for decerebrate posturing. And notice how the toes are pointed. So it's an extensor response to a painful stimulus. So a lot of times when you see a neuro assessment being done by the physician, they'll, I don't want to say instill pain, but they will, to see what kind of function the person will have. So whether it's a sternal rub or putting saline in the ears, so inducing pain and having an abnormal response to that pain would be decerebrate posturing, where the arms turn inward. This tells us that the brainstem has been affected. Oh, I said it backwards.
Yeah, I was about to ask you that.
Oh.
Because the cerebellum is balancing, right?
Yeah, so I always assumed cerebellum and cerebrate went together. So I guess I'm not going to assume that.
But
So
I
the
think
cerebrate
you're right,
goes
though.
with the brainstem.
Yes, you're right.
So even in my notes, I have decorticate is the above the pons and the midbrain. Okay. All right, so we'll go with the cerebrit means the brainstem has been affected. And then decorticate is the other position where the arms are flexed and the fists are tightly clenched. And that's considered decorticate posturing. So now instead of the arms going outward, they're being pulled inward in response to a pain. And the toes, again, are still pointed. All right, and what else? Oh, I need you to write a note for this. The Babinski reflex. Babinski is spelled B-A-B-I-N-S-K-I, Babinski reflex. And this is the toes extend when the bottom of the foot is, I have ... It's like, what do you say?
Stimulators?
Stimulated in the very center of the foot.
Oh,
Oh, okay.
I've seen the nurses, but like, they just like swipe up or something down. Like a
With their
syringe.
pen or something?
They'll do a pen or
Yeah.
syringe.
With the
Actually,
syringe?
now that you say that, I have seen that.
You have seen that?
Yeah.
They
I
just
didn't really
like,
think
this is
of
the bottom of the foot, they'll just go like that.
Uh-huh.
Like,
Yeah, they go up.
And the
Stimulation, see if they
toes
respond.
will, like,
React.
they won't close, they'll like extend out.
Oh, really?
Yeah.
Yeah, so if there's neurologic damage, instead of them going out, they'll just point forward and go to stay together. So that's negative, or is that positive?
So what should they do? They don't have to.
Like if I do it to you right now,
The toes will open up.
yeah, if I stimulate the middle of the bottom of your foot,
Mhm.
your toes go out.
I feel like I would just kick on
I
that.
think that's positive.
Red,
I feel
yeah.
like
I
I would
will
get
find
tickled.
it.
But if you
I would just
I
kick
like
on
kind of,
that.
I'd back up or
Like
something.
they reach to curl up.
You would
Your toes.
retract your leg?
Yeah, I'd be like, oh, no, don't do
So if
that.
the-
So what's a negative reflex, like?
No, no.
It not
If you don't
happening.
respond to it.
Yeah, if it's not happening.
Wouldn't they do
But
nothing?
they'll spread out, like.
If there
Would
was-
you do nothing if I did that to your foot?
If there was a brain injury?
Yeah, I think a brain
So with a brain injury, the toes stay together and point forward?
Oh, no matter what you do, they're just gonna be in that position.
Yeah.
Got it.
All right, and then the last is sickle cell disease that you see in kids. It's a genetic trait. Certain conditions cause the red blood cell to change shape when there's low oxygen or low pH. If there's rapid temperature changes, or if the kids are dehydrated, it'll cause the red cells to change their shape into a sickle-type appearance. The bad thing about that sickling is that it can,
Clot.
the red cells don't get through the capillaries very well. Clotting can occur where the red cells clump together, and now you've got diminished perfusion to different organs of the body, different tissues.
Wow.
So when that happens in the pulmonary capillaries, and you've got pulmonary capillaries that there's no perfusion, then the tissue will die, and it causes a lot of chest pain and just pain in general in the kids. Pulmonary complications are the primary cause of illness and death in patients with sickle cell disease. It's called acute chest syndrome when the patient presents with pleuritic or chest wall pain and shortness of breath. It's due to the pulmonary vessels being injured from the sickled cells. It leads to pulmonary infarction where the tissue beyond those blood vessels die from lack of oxygen. And another thing that happens is pneumonia can set in.